Welcome to the Special Operations Medical Association podcast series on prolonged field care. Any opinions contained in these podcasts are those of the authors alone and do not reflect U.S. Army, DoD, or U.S. government opinion or policy.
All right, so in this next series, we're going to be talking about pharmacology and sedation and pain control in the prolonged field care setting. So if you go to the website and you look at the capabilities paper where it talks about 10 kind of core competencies for prolonged field care, sedation and pain control is listed as one of those. Now, obviously, if you're a soft medic, you realize that one of your jobs is to control pain in a combat trauma casualty. But what we're trying to do here with these podcasts is to move people beyond kind of the TC3 mindset, move them beyond just putting a fentanyl sucker in somebody's mouth and expecting to put them on a helo. We're addressing the fact that there's a whole bunch of other skill sets that have to come into play if you're going to take this seriously. So the subject matter expert that we're bringing in for these talks is Lieutenant Colonel Brad Morgans. Brad is a CRNA, and he's been doing this since about 2002. So he started doing this stuff right when the war kicked off. So he has numerous rotations to Iraq and Afghanistan, as well as recent deployments to Africa and South America. So Brad has been in the remote setting. He knows what it's like to be in a resource-constrained environment. And he also works with soft medics all the time. So he gets the fact that we don't live up in an operating room where we're constantly using these medications and constantly dropping airways and have a ton of experience doing RSI. He gets it that we have a lot of other jobs we need to worry about and other things we need to be good at other than medicine. So this series on pharm is not just intended for the medics. We want to focus this especially on the medical director. So hopefully, if you and the doctor that's in charge of you are listening to the same subject matter expert talk about these techniques and medications, you'll be able to have a really good discussion and come up with a plan at the unit level and maybe develop an SOP there. Additionally, Brad is going to talk about the techniques that we're recommending in terms of procedural sedation, hanging a ketamine drip, why we include Versed and how much Versed we include, and also a little bit of discussion on morphine versus Dilaudid versus fentanyl, so that medical directors are speaking the same language as the medics. And hopefully these talks will enable really good conversation between the medics and the docs. And again, we're not saying this is how it's done. These aren't the prolonged field care guidelines like the TC3 guidelines. This is just good information from subject matter experts to help the medics and the docs that they work for make the right decisions specific to that unit and that unit's mission. So in this particular podcast, which is really just the intro podcast to this series of pharm talks, we're going to focus on the show notes. So if you go to prolongedfieldcare.org, look for a document that says Pharm Principles for Soft Medics, PHARM. So before we get into the interview that I did with Brad, I just want to focus on this document. So I'm going to run through it with you real quick. That way you've heard it once. Then you can go to the website, pull this thing off, and then really check it out. But it's really important that you understand these first 12 principles that we threw on there. These principles really set the tone for the rest of the talks. And really, their goal is to just keep you out of trouble and maximize your effectiveness. So principle number 1 is a bad memory is better than no memory. The patient doesn't get anything until his vital signs prove he can handle it. So the big question here is stable or unstable. And if a patient is even potentially unstable, we have to be really conservative with the medications that we're going to push. Secondly, you are expected to make pain manageable, not take it away completely. If you take away pain completely, that's called anesthesia, and that's not what we do. And we have to make this completely clear to our patients. And you're going to have to know the difference between sedation, analgesia, and anesthesia, as well as what drugs in your toolbox work to those ends. Next, if you're going to sedate a patient, you have to acknowledge the fact that you're going to lose their mental status as a vital sign. And this is really important for us when we have to make the decision between doing just opiate pain control on somebody or if we're going to go down the road of ketamine sedation. All right, next, we are not about cookbook formulas for doing sedation and pain control. Every patient is unique and requires a tailored approach. And we're not saying that you're not supposed to use cheat sheets. We recommend that you do have cheat sheets in all of your drug boxes that talk about the medication and its recommended dosages and maybe some techniques for administering the medication. But these are just a starting point to guide you because you're going to be under stress when this happens. But it's definitely not a one-size-fits-all approach. I mean, there's a big difference between how these medications react on people who drink and smoke versus those that don't. So there's just no way, especially in our community, that you're going to have a one-size-fits-all approach to these medications. All right, next up is titrate to effect. And I know everyone's heard this before and they've heard it a million times, but the point with this is patience. You have to be patient and wait for the medication to peak. If you don't know the time for peak effect for all the medications in your toolkit, then you don't know the medications well enough. You should know exactly how long you need to wait before redosing somebody to make sure that you're getting max effect of the medication. A good example is morphine, and we're going to get into this in depth with Brad, but morphine's got a much longer time to peak effect than fentanyl does. And it's pretty obvious how that can get you into some trouble. If you're not patient and you don't wait for the stuff to peak and you just keep redosing your patient because they're still in pain, you're probably going to give way more than they need. All right, next, your first experience pushing controlled medications should not be in a crisis. So if you're carrying the medication, you have an obligation to, number one, undergo training by a currently practicing anesthesia provider, and number two, to administer the medication under supervision during real cases. Just because you did a PowerPoint class on combat sedation and an intro to ketamine doesn't mean you're qualified to administer the medication. And that's a whole separate podcast that we're going to get into in terms of how does your medical director set up the training and who should you seek out to run this training for your medics so they're comfortable pushing the medications and you're comfortable sending them out the door on deployment with these drugs. All right, next principle. Performing procedural sedation on your own in the remote setting is a pretty big deal. And it's likely to be just one of many stressful things that you're going to have to do over this next day or day and a half that you're sitting on this patient. So in order to bring your stress level down a few notches, we really recommend that you consult. And the way we recommend you do that is that you assemble your equipment, you get everything set up, and you brief your plan to a higher medical authority. And when you have a physician on the other end of the phone who agrees with you that you're doing the right thing, it's going to take your stress levels way down. All right, this next one we have a whole podcast devoted to, which is MISMAID. So if you're going to sedate somebody, you need to have MISMAID covered, and that's an anesthesia acronym that stands for Monitor, Suction Machine, Airway, IV, and Drugs. And really, that's just a cue for an anesthesia provider. It's just a checklist so that they know that they have all the right equipment in place. And what we're saying with this is that if that's what an anesthesia provider has in place before they sedate somebody, you need to at least have thought through that checklist and have some sort of answer that covers each one of those items. Next point is know all your drugs inside and out. And there's lots of guys out there that can rattle off, the class of the drug, its indications and dosage and things like that. But when we say know your drug inside and out, we want you to know things like what we spoke of before, like the time for peak effect, and the red flags and the pitfalls that are common to that drug, as well as how you are personally going to dilute and administer the medication. So take ketamine, for example. The concentration I carry is 500 milligrams and 5 mLs. So I know that I need a 10 ml saline syringe. I'm going to end up wasting one of those cc's and replacing that with 1 cc of the ketamine, which is 100 milligrams. And that means I have 10 milligrams per cc in that syringe. So when I go to give that medication to the patient, I'm going to give it in 10 milligram increments. All right, next is take care of your medications. If they fall outside the temperature range, they may lose efficacy. And this is where we have to be really honest with ourselves, especially if we're deployed to a really hot region and the medications have been sitting in the sun inside our aid bag or wherever over and over again, day after day. You got to realize that those medications are going to lose efficacy. They're not going to work as well as they would have if they were temperature controlled. So when it comes time to give those medications, they may not work very well. Next point is avoid IM administration if possible. And the reason we put this on there is it seems like a lot of soft medics just default to giving medications intramuscular, and that's just really variable. And especially in a patient who's not circulating well because they're in shock, it's not a really good idea. So if you want to be a professional about this, we're going to give these medications IV or IO titrated to effect. So try to avoid IM administration. All right, and the last point is that a sedated patient always has a watcher. So it's just like somebody who's intubated. You'd never leave an intubated patient unattended. So the same thing goes for somebody who's got ketamine on board. You got to have somebody who's watching their airway at all times. So we recommend you go to prolongedfieldcare.org, download this document, review these 12 principles, and really make these the way you do business in terms of sedation and pain control. All right, so my apologies that you have to listen to me run my mouth for this 10-minute talk, but I really want to set up the rest of these podcasts with Brad so that you know where we're coming from. So send us your feedback to prolongedfieldcare.org and keep an eye out for that next podcast with Brad Morgans.